Now I am proceeding. This is the particulars of the patient. His name is Adult. He is 44 years old and he is obviously a male. And he is Muslim and his occupation is farmer. And he hails from middle lower economic status and his wealth and his installation are number ground by. And his date of admission was 15th April and we examined him on 18th April and he is not discharged yet when we examined him. And there is other information about him. And this is a particular list which we collected from his records. Then he complains. He came to us with fever for 15 days and he had productive cough for 15 days. That means that cough was associated with symptom of weight. And he had also respiratory distress or shortness in period for 10 days. And here is a graphical presentation of his symptoms. Then if we go to the history of present illness, according to the statement of the patient, because it was 16 days back, then certainly of high-grade fever and the highest recordable temperature was 100 degrees Fahrenheit, which was continued in nature. That is, the temperature did not alter by greater than 1 degree centigrade all the day, which was very indicating for pneumonia. And it was associated with chills and original wriggles and partially released by paracetamol. And then also the low productive cough simultaneously, it was scanty in amount and contained blood for first 3 days that later turned into rusty sputum with no reported diurnal variation. And we are continuing. Later he developed shortness of breath that persisted for 10 days and that was chest pain because of paralysis and got exaggerated by lying and believed by thinking that it is orthopnea with no reported seasonal variation in this syndrome. And patient gives history suggestive of dust allergy. He had amoxicillin benzenic acid which was suggested to him by DNF for a little bit pneumonia, but that aggravated his functions. And he has chronic minor leukemia for 8 years. Patient was non-diabetic and non-based. And he had no case of fever for 8 years as past illness. The drug history. Patient had been taking imaging for CML from 2018 and then switched drastically from 2023. He had also been taking calcium plus vitamin D3 complex and folic acid supplements from 204. The family history, notably hereditary lineage, was removed. The personal history patient was non-smoker and non-alcoholic, and he was found allergic to dust. And on general examination, we found his appearance as ill-eating, and the other was almost okay except the anemia. He was found moderately anemic, and in the DQPS, we found him to be preferred in deep propped up position. And on auscultation, the bilateral prints were found in the lungs. And in the vitals, we find a little abnormality in the blood pressure, which was 90 to 60 mm pressure, and the others are almost okay. The provisional diagnosis is community-acquired pneumonia with chronic minor leukemia. Here, community-acquired pneumonia indicates that he was not suffering from pneumonia within 48 hours of hospital admission. The ABCD results all are almost okay except the hemoglobin, which was a bit low. It was 7.8 gram per deciliter. We should not forget that he was suffering from chronic minor leukemia, which might be suggested in these hemoglobin results. And the others are almost okay. The clinical diagnosis was the same as the provisional diagnosis, and that is community-acquired pneumonia with chronic minor leukemia. The treatment given. Here is a treatment sheet. We find that Jerry gave ceftriaxone with 1 gram and 1 vial hydroxystrobin or the trade name diagnostic, tablet diagnostic, generic name diagnostic, which was suggested for chronic minor leukemia, paracetamol, substitute paracetamol, moxifloxacin as an antibiotic, and Windel Plus as nebulizer, which contains salbutamol plus hypertropia, and another inhaled corticosteroid, which is Buzdor, which is whose generic name was budesonide, and the other contains diet-normal, monitoring vital society and maintaining temperature. Here we are seeing two abbreviations, the STAT, which indicates static or immediately, and SOS, which indicates see or sit or only when frequent. And we are seeing some some blank boxes. The blank boxes were not filled by the physicians, and that might indicate some bad things about the treatment plan. Here is the treatment sheet with culprit pharmaceuticals. And here are the drug given, which only contains sedative and generic name, and the blank boxes were not filled by the physician. The results and outcome. The patient had some symptomatic improvements, but he was not recovered fully. Here is the summary of the case report. We should not follow it by reading it out. Now we come to the most expected part of our presentation, which is discussion about the problem and drug therapy given. First comes the definition. We use the definition of pneumonia. Pneumonia is an acute, not chronic. It is an acute respiratory illness associated with recently developed radiological pulmonary shattering that might be segmental, lobar, or multiple. The drugs given address all the family problems. Yes, of course. And if you relate the treatment, it contains ceftriaxone and tablet moxifloxacin, which both occurred as an antibiotic. We should see that the patient was on dual drug therapy. Not the physician did not only depend on a single antibiotic. There was two antibiotics going on, and there comes paracetamol, which was an antibiotic and analgesic, salbutamol plus ibuprofen, which was as a bronchodilator, and the infant corticosteroid glucosamine, which was to reduce infection here. Then the alternative treatment. Was there any alternatives? Let's see. First of all, we have to suggest some sputum for culture sensitivity and blood cultures to detect which organism is actually responsible for the disease. And before that, we should start empirical antibiotic therapy, which might contain the alternative to ceftriaxone as amoxicillin, erythromycin, doxycycline. The mechanism of action is written in one line here. And then it might contain the alternatives of moxifloxacin, which is levofloxacin, and the mechanism of action is written in one line here. Then we go to the next slide. And if the patient had severe pneumonia, we could have given the combination therapy of ceftriaxone plus erythromycin or ceftriaxone plus levofloxacin. Then let's justify the prescriptions by the physician. First of all, our physician was efficient enough to give better effectiveness, and we saw that he gave ceftriaxone plus moxifloxacin. If we go the ceftriaxone is excellently active against some ground-positive bacteria like Streptococcus pneumoniae, and the ground-native bacteria like E. coli, Klebsiella pneumoniae, and Pneumonia. So we do not see any atypical organisms here, but for the atypical organisms, we should go to moxifloxacin, which works against some atypical organisms like Mycoplasma, Chlamydia pneumoniae, and Ligium. It is also strongly suggested in the guidelines for strong pneumococcal coverage, including resistant strains. Here, resistant strains mean antimicrobial resistance, which is a global problem now. Secondly, the patient factor. We saw that the patient was suffering from chronic milder pneumonia for 8 years, so he is already immunosuppressed. For that, we started two therapies here. Then comes the dosage and frequency of therapy. We can see the ceftriaxone was administered every 12 hours to maintain adequate antimicrobial coverage, and the moxifloxacin was prescribed once daily, which is the standard recommended dosing frequency. Then the cost. We could think that as a patient is on dual therapy, it might get more costly, but if we see that it may cause higher success rate, faster clinical improvement, and a shorter hospital stay, which can reduce the cost overall. Then the duration of therapy is the community immune response within 5 to 7%, and the improvement often begins within 48 to 72 hours. So let's start criticizing the prescription. First of all, was the route of administration, dosage, frequency, and duration of the therapy properly mentioned? We can see all the three was properly mentioned, but there was no citation of the duration of therapy, which is a fault of the prescription. And the patient was not also warned about the possible adverse effects of each drug and how to manage them. Luckily, the patient did not report any adverse events. The final comment: the treatment plan was beneficial. It mentioned that other things except the duration of therapy and advice for management of adverse effects, and the patient had some symptomatic improvement but did not recover fully. Then we come to the drug discussion. The first drug was ceftriaxone. This is third generation cephalosporin or beta-lactam antibiotic, and its pharmacological effect is a broad spectrum. We saw the organisms it works against. Bactericidal antibiotic against many gram-positive and gram-negative organisms, and its mechanism of action is it binds penicillin binding proteins and increases peptide glycan cross-linking, which causes defective cell wall and bacterial life. For that, I need to show you something. That if the penicillin binding